everyone. My name is Dr. Sarah Cole. I'm an orthopaedic surgeon based in Cairns. And tonight is my great pleasure to hear from Peter Van Galen. Galen, is that what you like? Van Galen, who is a very wise, very senior, very experienced physiotherapist who is blessing us with his presence, and he's chosen the topic of ankle sprains. And obviously with an audience full of physiotherapists, we're not going to get too far into the nitty-gritty,
no.
But we want to hear some big picture, overarching themes of your career. How about that?
Perfect, thank you. So, as Sarah said, I'm a sports and manipulative physiotherapist, so I did these qualifications back in Perth in the dim dark days where they were graduate diplomas and they were clinically supervised, full-on nightmares, and they don't even exist now, but there's some current themes around ankle sprains that I think are worth keeping in the forefront of people's brains, because when we see ankle sprains come into the clinic, there's a lot of things we can miss. So that's why I thought this was going to be a good topic to refresh people's brains on. So what I'm going to talk about is just some anatomy stuff that's points of note, because I don't think we need to go back to first year. Classifications of injuries, some pointers around subjective examination, running through some objective assessment stuff where things are different and what might be cues to something more sinister than your bog standard ankle sprain. And why the topics? As I was just alluding to, why the topic? Because there's stuff that can be missed, and as I went further in my career in physio, I was getting to know a lot more surgeons and spending more time in surgery. For instance, when I opened a practice in Sydney, I got to know some foot and ankle surgeons. And going up and seeing patients and having a palpate of their talus, etc., before surgery, and doing instability tests, and then having a feel of it after surgery, and then being able to see under arthroscopy what is the surgeon seeing, it gives you a whole different appreciation of what walks in the door of your clinic when you see patients. So number one, we've really got to rule out fractures, and I'll briefly mention the Ottawa scale, but I'm not going to go into that in detail because that's pretty much a talk unto itself. The severity of the ankle injury, what is damaged and what can be missed, making sure we get the right ligaments, and how do we test for different ligaments for instability. And the important part about that is educating patients and setting expectations. Because if you diagnose early that someone has an intra-articular lesion as well as a lateral ligament sprain, i.e. they potentially have a medial talar dome lesion, your expectations of recovery and return to running, let alone walking pain-free, are very different. And you need to be able to articulate that to your patients so that they're not left thinking after 3 weeks, well, why can't I run yet? And how does it change your treatment and your management plan? And I think this is relevant not just to physios, but it's also relevant to general practitioners, because you guys, the general practitioners out there, see these things probably much higher frequency than we do, because I haven't seen an ankle sprain yet in my 8 months up here. So I'm kind of surprised. I'm sure they're happening, but we're not seeing them. Okay, quick refresh of anatomy. We need to be aware of the talocrural joint, which is what we most commonly think of with ankle sprains. The subtalar joint, because that can be involved, and sometimes chronic ankle pain can be due to subtalar joint injury, i.e. sinus tarsi syndrome, that the sports physicians talk a lot about. The inferior tib fib articulation, so this is now being called the high ankle sprain. And from my marketing days where we marketed a lot of products to really tie up the syndesmosis, I got to learn a lot more about the AITF, etc. Mid-tarsal calcaneocuboid. We need to be aware that your lateral fib calc ligament is back here. If your palpable tenderness is a bit further forward over the cuboid, it may not be your lateral fib calc, it may actually be your calcaneocuboid articulation that's the problem. Talar dome, as I've alluded to, and the fifth met, because the fifth met often has a mild, small hairline fracture. Talar dome, and I've always explained it to patients like this, when your ankle rolls and you roll laterally and you stretch all those ligaments laterally, if you think about the talar dome as 2 knuckles and they're sitting within the crust, when that rolls and there's impact, that medial talar dome is a ridge and it scours up into the crus or against the medial malleolus as that ankle rolls into plantar flexion inversion, and it can take a divot of that cartilage, which can be left as a flap. And if synovial fluid gets under that flap, the repetitive compression of weight bearing and running will start pushing synovial fluid underneath that cartilage flap. So you either get intra-articular joint signs and pain, like why does it feel like it's locking, like a knee locks? Or if the flap is loose, why does it feel like it's full of pressure? Well, what happens is the synovial fluid goes under the flap of cartilage and you get deterioration, you get a subchondral cyst. So you get bony breakdown. Okay, so that's just a taste of what should we be thinking about, what should we, and the anatomy kind of points us in that direction. So we go back to our bog standard lateral ligament sprain, and we're talking about the ATFL, anterior talofibular ligament, the lateral foot calc, and to a lesser extent the posterior foot calc ligament. We also need to look a bit further forward to our metatarsal row, and that's really the bifurcate ligament, which is your calcaneal cuboid ligament. 2 strips of it. Our anatomy around our tendons, we need to be wary of our peroneal tendons, and if the tendon is damaged and the sheath hasn't been torn, what you can get is like a sausage-like appearance of the peroneal tendons, and that's because the fluid of the tendon tear has stayed within the sheath of the peroneal tendons and within the retinaculum. It can appear like it's sausage. However, if the sheath tears, the peroneal tendon sheath tears, as well as the ligaments, then you need to be aware of that and what might the signs be and how might it be different. So classification of injury. I'm not going to go into fractures in a big way. I have come across the Ottawa scale. It has really high sensitivity for the presence of a fracture, but not specificity. So it can determine whether someone does have a fracture or not. And they found that in EDs, once the Ottawa scale was applied, they were managing to reduce the unnecessary use of radiography by 30 to 40%. From our side of the coin, we need to be aware of what are the telltale signs when someone walks into our rooms of a fracture, and why should we be picking them up, and when should we be sending them off for x-ray? Because we want to exclude that because it changes our expectations of recovery. And secondly, we wouldn't be treating them the same way if it was just soft tissue, would we? Ligaments, our grade 1 to 3. Do I need to refresh everyone's memories on grade 1 to grade 3? No? Everyone's good with that? Plus or minus capsular, etc. Grade 3 being a complete rupture. Tendon tears, tendinopathy. Have we created a tendinitis? Depends on when the patient sees you after the injury. If they see you and they've got what could be tendinopathy, they may have rolled their ankle. It may not be ligamentous, it may be purely tendon, or it may be a repetitive thing. So they may have a tendinopathy. Is it the tendon sheath that's been torn, a little bit like an Achilles paratenon? And what are the other things that might be going on for footballer, for instance? If someone's got a long history of football, can we test for anterior or posterior joint impingement? So repetitive kicking leads to spurring of the anterior distal tibia, right? So those footballers with repetitive kicks, they grow osteophytes off the anterior tibia. They start to get anterior tibial impingement. So the osteophytic spurs will start grinding into the talus, but they also have significant pain. They also lose their dorsiflexion range of motion. They've got posterior tibial impingement, they lose their plantar flexion. So that's obviously going to have a fairly significant impact to being able to sprint, a whole lot of different variables. So those are the sorts of classifications of injury that we need to be mindful of. So we're going rule out fracture, diagnose our soft tissue injuries, which ligaments, how severely sprained, etc. Is there tendon injury, or is there other things going on in the joint? Oh, that movement, that one didn't. I'm reading off this one. So, before we even start the subjective, you can be assessing your patient when you even call them in from the waiting room. You can see how they get up off the chair. You can see what walking aids they're using to get into the room. You can already get a whole heap of cues before you even introduce yourself. But most critically, we've got to ask them and really drill into, is their mechanism of injury? What do they recall about the mechanism of injury? Was someone standing on their foot as they were still accelerating? Did they come down from a tackle and roll by landing on someone's foot? Or a divot in the field, you know, what are those divots, those little pothole things, grass tufts and things. There's a lot that they need to be able to tell us. Were they going at full pelt? What was their speed? What was the direction of motion that they were going in? Was it just straight line? Were they cutting? Were they changing direction? And what other external forces might have been at play? That can give you a whole heap of information about the mechanism of injury and what might be damaged before you even touch them. If you ever want to learn a whole lot about ankle injuries, go to a country netball carnival. I remember going to one of those when I was doing sports physio grad did. You've literally got hundreds of athletes out there playing netball on something like about 45 different netball courts. And I truly learned the difference between a fracture and an ankle sprain. Because the people that scream the loudest usually had soft tissue sprains. The people that go pale and don't scream, they've been crying, but they can't even weight bear, they've usually got ankle fractures. Either fibula, fifth net, or something else. So mechanism of injury is really critical because it will hone in where your objective examination goes to. How did the patient manage their acute injury? Did they immediately ice it, or did they go out on the booze? Common one. Two extremes, I know, but how did they manage it? Did they immediately get off it? Did they continue playing? Did they get off it and did they ice it? Did they put compression bandage on it straight away or as soon as possible? Etc., etc. That can give you some good cues as to, you know, how bad this ankle injury might be. Past injury, past history, really relevant because we want to know whether it's recurrent, whether they've potentially had instability. Often people with instability, they've damaged it a couple of times before and they're lax and they're unstable. When they roll it again, they tend to not get the huge soft tissue swelling signs. They tend to be different, and it's because when they tear through scar tissue, it just dissipates really quickly, and they're used to it as well. They're used to this sort of pain. So sometimes the unstable ankle that is recurrent doesn't tend to appear as serious, but in actual fact, it's probably more serious because they could well have done more intra-articular damage. They could well have done bony damage, etc. The other thing to really drill with your patients is, what are their goals? Where do they want to get to? Are they a high-level athlete? Are they a ballet dancer? What level are they at in their sport, and what is their goals to get back to? Because if we're setting parameters about our expectations of speed of recovery and what will that rehab course look like, we need to know what level we're getting that patient back to. Is it some of my patients from Harmco that just need to be able to do their 5K walks every morning with the dog, or are they doing 30K runs and Ironmans and stuff like that? So we've kind of got both extremes up there. Getting into our objective examination, I think it's good to start with some functional tests before you even get them on the slab, because the functional tests will really hone in to them and you what you're looking for, so that your objective examination becomes a bit more targeted. I like the two-legged squat because it gives us an immediate appreciation of their dorsiflexion range, and then I take that to the next step with knee to wall and comparing the two. And this is where, if they've got a restriction of range of motion with knee to wall, what I'm looking for is their anterior impingement that's causing the pain. Is it posterior? And is it gastroc versus soleus? Those sorts of differentiators around what might be restricting that dorsiflexion. If they've got a restricted soleus and their soleus range in comparison to their gastroc is out of sync, their soleus may be actually stopping their dorsiflexion range of motion. It may not be their ankle sprain. Single leg stance, I like looking at single leg stance because it gives you an idea on not just a little bit of early proprioceptive input, but it actually gives you an idea about how comfortable they are standing on it, how comfortable is weight bearing. It almost rules out fracture, not categorically, but if someone can stand and they've got good, they can stand and they can close their eyes for 10 seconds and a few other things like that, then you've got a fair appreciation that they're not that uncomfortable with weight bearing. They may not have too much synovitis in the joint, etc., etc. It's just cueing you in. When we get to palpation, it's wise, and someone brought this home to me when I was looking at a practical course online. You gain a patient's confidence by touching them and then getting used to your palpatory feel if you start well away from where you think the damaged structures are. So they're getting used to, they're getting comfortable, and they're developing confidence with your touch. And you can also start with non-sensitive structures so you can work out how sensitive is your patient before you start touching sensitive structures. If you believe they've got a lateral ligament sprain and you start touching their medial joint line and they're screaming, you can guarantee that by the time you get to the structures that you think are, then you're going to have to be really, really gentle. Where is the swelling when you're palpating? Is the swelling like the egg over the anterolateral ankle? Or is the swelling really profuse and generalised, and can you already see bruising that's dissipating through the dorsum of the foot or down the lateral border of the foot? That gives you a cue. If there's bleeding and blood that's already leaked out, you can guarantee that the sprain was pretty severe to see bruising. Is bruising going back up the perineal compartment? And why does it go up the perineal compartment or the anterior tibial compartment? Any ideas? Why do we see bruising going up the lateral compartment of the shank? Muscle pump. Muscle pump sucking it up. You sometimes see it coming right up through the anterior tibial compartment too. So it's clearly a very leaked capsule, and the muscle pump is just sucking it up as they're getting movement happening. The muscle pump is sucking. I've seen bruising, or you've also got muscular damage up here in the perineal compartment or the anterior tibial compartment. If it's a bubble, it's nice to see the bubble over the anterolateral ankle because it's contained within the capsule. So that gives you an idea that the capsule hasn't been ruptured. And if the capsule hasn't been ruptured, you've got lesser grade of ligament damage. So if you can get rid of the bubble and you can get that swelling down really nice and quickly, it augurs well for a quick recovery. We've talked about ATFL and lateral foot calc ligaments. Perineal tendons, as I said, it can appear like a sausage if the swelling is still contained within the sheath. The high ankle sprain, that anterior inferior tibiofibular ligament and the posterior inferior tibiofibular ligament can be completely separated. So the syndesmosis can be completely stretched apart. They talk about the Weber fractures going up into the malleolus, how far up the fibula and all that sort of thing. But when you do a decent enough ankle sprain and the talus stays high in the crust and it separates the tib fib strongly enough, you may actually notice your palpatory tenderness is not necessarily over the tib talus, but it's further up at the distal tib fib joint. And if that's where your tenderness, you need to rule out the syndesmosis being separated. Because if it is separated, as soon as that patient becomes weight-bearing and you start getting into more propulsive and explosive type of activity, if that's going to keep bouncing apart, you're not going to get a good recovery. It needs to be locked back up. So the high ankle sprain needs to be included or excluded from your bog standard anterolateral ligament sprain. Obviously medially it's the deltoid ligament, and as I alluded to before with respect to the talus, when you're palpating you want to pay some special attention to that medial talar dome or the lateral talar dome. Take the patient's foot into plantar flexion as much as they're comfortable with. As you're palpating up, go up to the medial ridge of the talar dome. If it's really tender and you know you're not on the tibial plafond, if it's really tender, take the joint up into dorsiflexion, and if it's more tender, you more than likely have a talar dome lesion, whether it's just a flap of cartilage or just a scouring of the cartilage, depending on what level. Any questions on that?
That's right, I've got lots of questions.
Oh, have you? She's keeping them in her
I've got them ready.
Got them written down.
Instability tests are quite important, getting comfortable with instability tests. The anterior draw, what I've got a picture of there is the reverse anterior draw, where you're fixing the tibia and the fibula, and you're getting a full grasp of the calcaneus from behind, and you're drawing the talus forward from the calcaneus. Okay? A true anterior draw is the foot is placed up on the bed, it's in slight plantar flexion or mid-range plantar flexion, and you are fixing the talus with one hand and you are pushing the tib fib back with the other hand. What you're looking for is the sulcus sign. The sulcus sign is like a little gutter that forms anterior to the fibula but a little bit more proximally, and you see this sulcus form because it's just so sloppy and so loose, either with the reverse or with the anterior draw. Good to do both depending on the comfort of the patient, because you might get a more relaxed patient if you're doing a reverse anterior draw. Talar tilt, you take the talus, you take the foot up into dorsiflexion and eversion, and what you're doing is you're fixing the foot fixing the foot medially with one hand, and you are grasping, taking it into dorsiflexion, eversion, grasping the calcaneus from the outside, and you are tilting it. Got that? And you're looking for laxity. If it just moves all out of control, then you know you've got laxity of that ligament.
Laxity of?
So that's a lateral fib calc ligament. So the anterior draw, sorry, I should have been more specific. The anterior draw and the reverse anterior draw is more your ATFL. Your lateral, the talar tilt is your lateral fib calc ligament. And if you're getting both positive on a patient, you've got a pretty sloppy, unstable ankle potentially. The bifurcate ligament, you stabilise the calcaneus with the opposite hand. You try and grasp the cuboid with your hand coming around from the outside, and you're trying to grip the cuboid with your forefinger and thumb.
Yeah, you just see it.
It's about feeling.
So you're fixing medially, grasping laterally, and you know that you've got to be back from the fifth met head. So what do you call it, the styloid? Is it styloid?
No, it's not that, but it's...
You're gripping the calcaneus and you're really trying to get some inversion torque and some adverse APPA laxity.
APPA.
Anteroposterior and posterior anterior.
Thank you. Physio.
That type of movement. AITFL.
I'm keeping it.
You take it up into maximum dorsiflexion, external rotation.
That's Lisa.
Yeah.
Oh,
Yeah, ignore that.
great examination of the foot going on here. And when you take it up into full dorsiflexion and you get external rotation of the foot or the talus within the crus, and you reproduce their pain, you're pretty likely to have some separation of the. But that's also going to fit with your palpatory findings. Makes sense? And you can also take that a step further for the AITFL, and that's with the knee to wall test. What you do is you strap up the inferior tib fib joint with some rigid sports tape, quite tight, and then you take them up into dorsiflexion with the knee to wall. And if the knee to wall is better and they have less pain, it's because the diastasis didn't separate. So you kind of can use that as a functional proof test.
I do the same thing with the wrist. Just radiometer.
Yeah.
We stabilise the disc radiometer. Very double TXs.
Yeah.
It's the same principle.
Last one, posterior impingement. If you've got some osteophytes posteriorly around the back of the ankle, either due to repetitive dorsiflexion strains, who knows, you jam it up into maximum plantar flexion, either in long sitting or prone. It's probably easier to do prone with the knee bent at 90 degrees, and you really literally
That's
Yeah.
what I was going to say, like, hey,
plantar flexion, plantar
You're on to
flexion,
you.
and you're literally giving a good slam. Okay. Whereas if it's anterior impingement, you're going to have limited dorsiflexion, and that goes back to your basic passive movement testing. If you take that foot into maximum dorsiflexion and you've got spurs in the anterior, across the anterior plafond of the tibia, they're going to be in massive pain. Certainly with knee to wall, and certainly if you do a passive test. Good fun? So that's really going from instability into some more differential diagnosis stuff. And then depends how sophisticated you really want to get. We're obviously doing muscle tests for pain reproduction because it kind of cues us into more about what we might need to work on. But a lot of people get carried away with dynamometry. I personally don't. If I was working with a lot of elite athletes all the time, then I probably would, because then you've got objective measures that you can go back to. It's your benchmarks from right at the start, and you've got follow-up benchmarks that you can. It's up to you. It's up to you about how specific you want to be, and it's also good to show the patients if you want to be that in depth. Proprioceptive testing. So that's good. Single leg stance. I always do the good leg first, unaffected leg first. Get them stable. Make sure that their leg isn't touching the other leg, because that's a cue to stability. Eyes open first, and I get them to close their eyes, and I see if I can count to 10. Most people with an acute injury, they should definitely be able to get past 10. If they've, certainly on their good leg, if it's a significant sprain, or if they have recurrent injuries, from a proprioceptive point of view, they might be hopeless. And they might be hopeless on the other leg as well, because they may have sprained that as well. The STAR excursion test, is anyone familiar with that? Good.
Tell us.
Injured foot standing in the middle of the STAR, standing whether it's the left or the right, and this is just tape that you put on the floor.
Yeah.
So you stand in the middle of the circle, whether it's the left or the right limb, and the other limb goes either straight ahead, which is anterior, out to 8 o'clock is left leg, 8 o'clock is anterolateral, 7 is lateral, straight lateral, 6 is posterolateral, and 5 is posterior, 4 is posterior medial, 3 is medial, and 2 is anteromedial.
What? What are you doing?
So you're standing here, so they're standing here, and you're on a STAR, and you're trying to measure how far they can put their toe and retain stability of that foot.
Got it. Okay.
Yeah,
So,
you're testing things on
are they stable or are they not when they go through? And if they go around the clock and then they start to get unstable, you can work out that they're unstable over that area. Over here or there.
Based on the planting. Right, yeah. Planting.
Makes sense? This is probably, some of the basic stuff is what we would do in an acute injury, but some of this stuff, like the STAR test, the zigzag across a tape line, and the sideways hopping for 30 seconds, this is really where we're getting to mid to end stage rehabilitation, and you're trying to get someone to their maximum. And you're demonstrating to them, this is where your proprioception is not good, and this is where we need to improve it, and this is why these drills are important, because otherwise you will likely re-injure this ankle again. So it's kind of adding evidence and proof to that. The zigzag is really, you've just got a line of tape down the room, and they have to hop sideways across a line going down the room on the injured foot. And side hops is just going side to side for 30 seconds, as many times as they can across a 40 centimetre distance. And you're timing it, and you're counting them. Good baseline for future rehab.
So I have many questions, but I can say...
Same, I have many questions, but I think we're just about, that's enough slides.
Yeah?
Yeah, okay, so we're now allowed to ask our many questions. Is that allowed?
Yeah.
Actually, for star
Just take
balance,
your,
we actually have used star balance and wide balance for them as well. So you put them in push-up position for star balance, wide balance, and stuff.
Yeah.
And then you're
I
measuring
like that.
lateral positioning.
So it's proprioceptive of the shoulder. And it's often the forgotten bit of the shoulder.
It's handy post-operatively, because sometimes I get them to do a push-up, but I wouldn't think of getting them to... Yeah.
That's one, so it's proprioceptive, but also patients holding a heavy ball, when they're lying on their back, can they close their eyes and feel with their shoulder? Can they feel with the medicine ball whether their arm is wavering or not? And a lot of them have no idea with the shoulder proprioceptively, because they've lost it, especially with an instability. They've got no idea where their arm is in space, which gives you a cue that's where you have to have a focus on rehabilitation. It's not just about strength.
But yeah, okay. Yeah, I do struggle to get that proprioceptive message out there. You're right.
So when it comes to... Sorry, thank you. When it comes to... I really appreciate this, that's actually very insightful. When it comes to your balance assessments and stuff, so we're starting acute, progressing towards, post. What's your pass? Because, so 10 seconds, single leg stance, okay.
That's good for an acute ankle, but for a later ankle, mid to late stage rehab, that's not a pass.
Skip that test altogether.
Yeah, that would be a proprioceptive test that I'd use early in the process, but with you getting to mid to late stage rehab, especially with someone that wants to be an elite sport person, it's useless. You've got to step up to much more advanced proprioceptive testing. And I've seen this fancy mat that is... Yeah. I don't know where you get them though.
Oh, it's a branded thing.
Yeah.
I mean, if you got a picture, you can recreate it yourself.
You can just put it on the floor.
Basically, that's all we've done.
Are you trying to determine when they can return to
We
play?
haven't that.
It's not just about returning to play, it's also about if they are going back to elite sport or high level sport, you've got to make sure that you have tested them at a high level, because you want to prevent re-injury. And you also want to be able to prove to them and their coaches and trainers that will be pushing them to early return. You want to be able to prove to them why it's a risk. Because if you haven't got anything objective to say to the coach that this person is potentially at risk if they go back now instead of waiting another couple of weeks, and that also gives you a couple of weeks to work with the athlete to say, you know, you've got to work on this. It's not just about strength now and getting your run-throughs up to speed to full sprint pace. It's also about this balance stuff, because this balance stuff is what's going to stop you re-injuring. Otherwise, you'll be back here in 2 months.
Yeah. can say, yeah, that's an easy sell.
And that's one of the hard things for us, especially when we're working with teams, is being able to sell a message to the player and to their coach.
Mm-hmm.
If you want to protect I always think about protecting the athlete, because the athlete is a person. It's not about achieving a goal so that the team can win the semi-final. I think that's where my responsibility lies. So you've got to have things that are objective, that are factual, and they're not emotive, and they're not, I think that it would be better if we waited another 2 weeks, because the more wishy-washy you are, that you'll never sell the message.
I'll never hear you say.
Just to build on that one more time, and I'll hand over the What's your, I'm full of opinions.
You'll be doing a talk next year.
What's your, in your experience, what are your general timelines for sort of signposts and milestones for getting someone back to play? Because historically, like thinking of people presented working with the ballet and circus, anyone who's had a relatively significant ankle injury, there's a level of instability that they deal with for like 9 months before we're like, okay, you can finally take that brace off. So what do you look, where do you go, okay, weeks 1 to 2, we're here, weeks 4, we're here, 10, 8, you know.
Great question. And I love referring back to one of Australia's older Olympic physicians, Dr. Ken Fitch, who was one of our lecturers, and he set up the course over at Perth in sports physio. Now, Ken Fitch, they did some studies there at a sports injury clinic at Royal Perth Rehab Hospital, and they measured a whole lot of ankle sprains, and they measured and they found that the critical thing was the time to get back to running for a grade 3 ankle sprain was 3 weeks of physio plus the number of days from injury to first presentation of physio, which I thought was a really good benchmark. 3 weeks for a grade 3 ankle, bog standard, ATFL, lateral foot calc, no Taylor Dome stuff, 3 weeks. By 3 weeks, you should be back at some run-walk program and some weight bearing, getting speed back. You should have relatively close to full range of motion. You may still be working on dorsiflexion mobilisation. You're still working on strength, you're still working on proprioception, but they can start doing some gentle jogs. Forward jogs, backwards jogs, sidestepping as they build their confidence. If it was a ballet dancer, it might be less than that. You have to really gauge it really carefully with how severe the injury was, whether there was any intra-articular lesions, and anything else that might be raising your suspicions of a more protracted rehab course. And that's why I think mechanism of injury, classification of the severity of injury, possible internal derangement, medial Taylor dome. If it's medial Taylor dome, after I watched so many ankle arthroscopies, I got good at picking them. I got to the point where they would come into the clinic, and if I palpated that and it was just such a blown up joint, I would say to the patient, I think you have done more than a soft tissue ligament injury. I think you have done something inside. Now, we could send you to a foot and ankle surgeon now for an opinion, but he's probably going to say, come back and see me in 6 to 12 weeks when you can't run. Because that patient with an intra-articular lesion will not get back to jogging in 3 weeks, which was our first milestone, right? If they've got an intra-articular lesion, they'll be struggling getting back to any running, and they'll still be limping with walking at 6 to 10 weeks. And that's kind of your benchmark. And that's kind of telling you that what you saw or suspected early on, and when they don't hit those milestones, they can't jog at 3 weeks, they're still having problems walking without pain or prolonged standing in 6 weeks, that's when it's time to get them seen by an orthopaedic surgeon for an opinion. Hey, I'm at 6 weeks and MRI, Does it prove it? Do we do anything about it now, or do we give it more time? Because chances are an orthopaedic surgeon is not going to do anything until that patient's been rehabbed well and they've got rid of swelling well and they're still struggling to get back to running at 10, 12 weeks or something like that.
If you arthroscope a synovitic inflamed irritated ankle at all, you get the denser scarring. You get denser adhesions in there, so you want it a little bit, if you can get it a bit quiet, and shoulders especially, you get them a bit quiet, then they respond better to an arthroscopy. Another question?
Does that make some sense about timelines?
Yeah.
Timelines and expectations?
Yeah, so 3 weeks for the sort of bog standard ligament only, soft tissue only. And then if there's a internal arrangement to that, like structural issue, then we're now looking, it's going to be longer than that 10-week mark, but that's your, hey, here's the cutoff to go and now get someone else to do it.
And also, if it's a high ankle sprain and if the syndesmosis has been stretched and separated, by 3 to 6 weeks, if that's going to heal, it'll tighten up. But if it's sufficiently lax, they won't be able to run, because every time they impact, it'll be pulling the inferior tib fib apart.
So it's going to present similarly, but still different.
Yeah. So that's why your palpation and ruling in or out the inferior tib fib is really important, because it changes your expectations. If you can say to someone early on, I think you've done this to the inferior tib fib, we need to see how this progresses before we'll know categorically, unless you want to pay a whole lot of money for some investigations. If at 3 weeks they can't run, they can't take it in, you can say this kind of confirms, let's see how it progresses. If at 6 weeks you can, then maybe it's healing itself up, etc.
Thank you.
That's all right.
Because that medial talar dome, that can be just a little bit of bone bruising. That can be an impaction fracture. That can be a loose body. That can be a cartilage flap. So
a whole lot of things.
So each one has an ability to heal, or 2, an ability to be surgically correctable, and that's hard to judge just by palpating them.
But you look good at 6 weeks when you've already kind of forewarned someone, and that also changes their expectations. Because if they're not running at 3 weeks and you forewarn them, you can remind them, didn't we have this conversation? This is a possibility. We need to just take this slower to see what happens, and then consider further investigations or opinions.
I appreciate that everything's contextual, but what I find is sometimes the hard conversations when they say, oh, but someone in the football, they they've got high ankle sprain, so they just wanted to tightrope and then they were back playing 6 weeks later. So why would I bother waiting for 6 weeks if I can just go and do that? That's what I mean when I say it's contextual. Because I guess, how do you manage that conversation?
I ask, well, first of all, if you've already established what people's goals are and what level of sport they want to get to, B, if you forewarn them that it's a possibility, you're kind of going to get a read from them as to whether, well, I want to know. Because if they want to know, okay, go and have an MRI. I can send you for an MRI. It's just as expensive as I send you or your GP sends you. Go and have an MRI. It may not definitively prove it. If you've got that, depends on how much you want to have surgery. If getting back to sport is your primary goal and doing that really early and quickly, then, go and see an orthopaedic surgeon, get a tightrope stuck in there. I used to market them.
That leads on to my question. So do you understand what a tightrope is? Okay, so obviously our general practitioners are unlikely to understand what a tightrope is. So in respect to them, so my question for you really is...
is it better than a screw?
No, I wasn't going to ask that one actually. I do want to ask that, but I'll save it for another time. How good is the tightrope? Like, Do you like it? Do you think if they've got a little bit of AITFL, you know, just bung in a tightrope? Or is it more you really want to see an unstable, miserable...
Yeah.
Really?
That would be my gut feel.
Yeah.
I wouldn't send someone straight down the road of having a
So you
tightrope
see it on
stuck
the
in.
MRI scan,
Unless
goodness.
it's your patient and the context was, I want to get back to sport really quickly and blah, 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 blah. So we'll go down that road. But my preference is, let's just see how you progress. Because if your instability of your AITFL and your PITFL heals just as the AITFL heals, for those on Zoom, anterior talar fibular ligament is your basic anterolateral ligament, whereas AITFL is really the anterior, between the tibia and the fibula. That can tighten up and heal if it's a grade 2 sprain. If it's grade 3 rupture, yes, it can tighten up, and the capsula of the third joint can tighten up, just as the ATFL, the lateral fibula, like any joint. It can tighten up. It could restabilise itself. But if it doesn't, that's when it's worth pursuing.
Good.
It's also about trying to manage people's expectations of, you know, you don't just have an anaesthetic and have surgery just because you can.
Because you've had an injury.
Just because you've had an injury. Your body needs to repair itself. And why don't you let your body repair itself and see what you're left with before you rush off and have surgery prematurely? It's not unnecessarily, because you might still end up there, but it's about whether it's really justified.
You deliberately haven't seemed to talk much about treatment, and from a GP perspective, my question for you is, what's your opinion about a moon boot in this context of this discussion?
Look, I think a moon boot is indicated if you've got a fracture.
Thank you.
I don't think it's an indication with a grade 3 ankle sprain rupture. I'd put people in rigid strapping tape. It contains their swelling, it gives them stability, and it gets them walking more normally. So you immediately get the weight-bearing forces, which is going to help get rid of synovitis and swelling, and hump gets moving. You start getting, you're protecting the healing damaged structures, because the rigid strapping, there's no way you're going to take that to end of range. You're going to have someone functioning, and with a full rigid ankle strapping, I then get them to do ice immersion. Ice immersion is super painful, but super effective than an ice pack. And I warn people, I am the physiotherapist from hell. Because
how long do you immerse them for?
you immerse them, so here's my golden rules. They start with cold water, they start adding ice. And they keep adding ice until it appears to stop melting, and that's around their foot. And once the ice stops melting, they've got it cold. And that way their foot has learned to accommodate to the cold, because it's bloody painful.
Go on.
Then, as the ice starts melting, they should start putting some more in. Now, from the time they stop adding ice, they then put the timer on for 20 to 30 minutes. The reason I say 30 is back in my sports physio training days, how long should you put ice on? And all of the studies say that if you take ice off before 15 minutes, you get a deeper reflex vasodilatation. And it oscillates till you get down to 28 minutes. And at 28 minutes, it stays, and the oscillations are less, and it stays, and the deep tissue, core tissue, stay at that lower reduced temperature for up to 2 hours. So for ankles, get in a bucket of water.
Got it.
And if it's knees, wrap that ice on. It's got to have a wet layer between the plastic bag and your crushed ice on your skin. And it's absolutely for 20 minutes, and it's firm compression. And people say, oh, so then after 48 hours I start doing hot and cold. No, you do not. You keep doing ice as long as your ankle is swollen. As long as your ankle or your knee gets hot after you do exercise of any description, you go back to ice. Go back to ice. It's the best thing. But when the ankle is starting to recover and that swelling is going really
Yes.
boggy and custard slice, vanilla slicey, when it gets to that sort of consistency of swelling, not only am I doing a lot more massage type of stuff, but I get them to do contrast buckets. Just warm and ice. You start with ice, you finish with ice, and you do it for 20 minutes. 2 minutes in ice, 2 minutes in warm. In, out, in, out. The contrast bath, doing this constriction, dilatation, you're getting that vascular pump on all of that boggy, shitty swelling. Got it? I'm not plotting now.
Come hang out here.
Management of the tip of fibular fracture, so the avulsion fracture of the lateral collateral ligament.
But I'll still do strapping, because if they've got soft tissue injury as well as that avulsion, it depends on where the fracture is, the avulsion injury, but you want to make sure it doesn't come adrift. So you want to lock up the ankle from a soft tissue perspective, but you need to protect the fibula and the fracture so it doesn't sublux and become unstable. But if it looks like it's going to come adrift, then that's when it potentially becomes an internal fixation thing.
I don't think I've ever fixed it.
No.
Because they just really,
They heal.
must be so rare that, I mean, but you do see the loose bodies down the track.
And you can lock someone's ankle up with a fibula, very tip of fibula avulsion. You can lock it up with really good rigid taping, and they can feel super comfortable. But if you want to be super sure, you put them in a moon boot as well.
Oh, I was just reflecting on the strapping and the calf muscle pump. I think you must reduce your DVT rate if you allow them to continue to use their calf muscle
And
pump,
walking.
and so that would be the benefit of the taking over the moon boot in the acute, in the early stages.
Yeah.
I think GPs would be because it's easy to acquire a moon boot. It's easy to put them in a moon boot, but if it's also easy to refer for strapping,
Yeah.
then that sounds like a better option for the patient. If they've excluded a fracture, then they can refer for strapping rather than refer for a moon boot.
Absolutely. And that strapping, as soon as you get patients walking, they walk in on a crutch, and you strap them up and lock them up, and they feel comfortable.
They walk out without their crutches.
They walk out without their crutches. You look good. But clinics never look good with patients walking out on crutches or their walkers. But also, you're getting that normal proprioceptive stimulus from weight bearing. You're getting the calf muscle pump. You're also, with the limited amount of movement with the strapping, you're getting that gentle movement of plantar flexion, dorsiflexion, even some basic, minimal amounts of inversion and eversion, which is going to help that early scar tissue deposition. You want the scar tissue to lay down along the lines of stress. You want to protect it, but you want to lay scar tissue down along the lines of stress.
Yes, agreed.
If scar tissue behaves, if it's like matted hair, this is how I describe it to patients. It's like matted hair, and it lays itself down like a spider web and a cobweb. What happens as it matures, it contracts and pulls in. If it's matted hair, it pulls in all directions, which means your range of motion is restricted in multiple directions. If you influence that scar tissue laying down so it's along the lines of stress, it's parallel to the lines of stress, it means that the scar tissue is supporting the ligament or the damaged tissues along those lines of stress, and you can facilitate normal range of motion much more quickly. Also, as the scar tissue heals, if it's deposited itself along the lines of stress and it's healed and shortened while you're still pushing to get full range of motion, it's less likely to recur because it's become mature scar tissue and its lines of stress, it's protecting in the direction of stress that it's supposed to.
I'm sure if you've got any more questions, just interrupt me. Medial ligament repairs.
What about them?
Have you seen many?
I haven't seen any.
Great. That's an excellent answer. So it's not very common.
A medial ankle sprain is much less common anyway.
Yes.
But the true instability from the medial ankle sprain,
Yes.
I think, I've never seen them, and I never saw them in surgery in my
Didn't you?
years in marketing. No. I know that they do repair them, a bit
Yes.
like they do primary repairs of MCLs of the knee and stuff like that.
It's just sometimes it's reported on the MRI scan. You know, they get that sort of intra-substance tear, and then there's a whole conversation about what should we be doing about the medial collateral ligament. And my temptation, because it's such a thick, broad structure,
It's got
not
two layers.
wispy like it's not wispy like a lateral. It's like a big chunk of
heal.
tissue. I just wondered if you'd seen
I
it
would-
repaired much.
I would imagine it would heal.
Yes, it does.
And we
I
don't
think so.
We don't see that many of them. I don't.
That's my impression.
I
Clinical
don't see
impression.
many medial ligament
Recons. Good.
or injuries.
Maybe in the context of fracture, but not.
Yeah,
Okay, good.
because if you're going to tear that medial ligament, it's really big. You're likely to be doing some Weber class
Yeah,
A,
yeah,
Bs,
sure.
or Cs at the same time. In which case, if they're going to go in and put some screws in there for a Weber, whatever, they might as well sew the thing back together. But if it's just a ligament injury in the deltoid ligament, I reckon they would heal probably much better than intralateral.
True.
You just don't see them.
I tell patients with the ATFL and CFL that they probably did their ATFL when they were much younger. So if they're coming with an ATFL and CFL, that's what I call it. I can't remember what you call it. Is that fair? Is that fair that they've probably done it, the ATFL in their 20s, and then they're coming with this big ankle sprain in their 40s?
Possibly, they may never have done it before.
Really?
Yeah.
It could be a fresh ATFL.
Could be. But it's unlikely because most people roll their ankles at some time in their childhood.
That's what I
years.
assumed. Yeah. It's just in the context of a work cover claim. If they come in with an ATFL and a CFL, were they predisposed? Don't know. Good. Okay. Any opinion?
And if
Some common pre-existing injuries like that. I'm aware of the one, where are you referencing to? Because we're here for that conversation as well. About pre-existing injuries that they get exacerbated by work processes.
Yeah.
But I'm sorry, I want to get a bit better. Sometimes, we get a patient now who's in their 50s and they've never hurt their ankle before in their life. And
Right.
or they might have hurt it on the other limb.
Yeah, of course.
They've
Yes.
been done on one limb.
Yeah, they can't always remember. Okay. Good. Perineal splits. Do they heal? Yeah, I presume you've seen them repaired, perineal splits.
Yes,
in the tendons?
and I wondered why.
That is really my question. I mean, I think I have seen a long-standing perineal split with like a really degenerative kind of.
Becomes stringy and strange. Yeah.
Yeah, it looked really abnormal. But
If you get a
So I-
longitudinal split of a
Yes.
tendon,
yes,
you have to ask yourself, why would you do anything and why is it causing pain? If it's contained within its sheath and it's contained under the retinaculi,
yeah,
it
I'm
passes
much more
under.
interested in the retinaculum.
Why would it be a cause of pain just because the tendon split? If you think about a rope, if you split it down the middle, it's still got its tensile strength. From a biomechanical point of view, it's still doing its job. So why would it cause pain of itself just because it's longitudinally split?
Good.
If it's frayed, however,
Yes.
and it's lost 50% of its tendon fibres have been torn through, you've got a partial
Easy.
rupture,
Yeah.
then your justification for doing anything is very different, and the reason it might be a cause of pain is very different because it's weak, it's been stretched, it's been elongated, it's potentially leading to instability of the ankle, if not the subtalar joint. But if it's just a longitudinal split, unless it's frayed and it's torn away, I can't see why it would cause pain, unless the retinaculum has been severed. And then you get a subluxing tendon.
What
potentially.
proportion of subluxing perineal tendons would be presenting with pain?
They usually present with that functional it flex.
Yeah. Do
That's
they
what
present
they
with pain? I don't often see pain. They can show me the cardi trick
Yeah.
sort of thing. You know, like, look, it's clicking. And
But it doesn't usually cause pain. unless it's flicking and causing a bit of
Tendonitis.
tendinopathy.
Yeah, sure, fair enough.
Because
I
it's
understand.
flipping and where it's rubbing around the lateral
Mm.
malleolus, but doesn't usually cause pain.
Right.
In track and field athletes, however, when we're talking post tendons and flexors ulnar tendons and all that sort
We
of
don't
thing,
start.
it's a
That's a whole different
ball
presentation.
game. Absolutely. And the perineals don't, in track and field athletes, except the high jumpers, doesn't tend to be, the perineals don't tend to be the problem in track and field.
Excellent. We've hit time. We've hit time. It's done. It's done. You survived.
Am I off the hook?
We can turn off the cameras and we can ask the real questions. Thank you so much. Thank you so much for coming.
You're welcome.
Really
Thanks, Sarah.
appreciate your
Thank you for
presentation.
inviting me.
And I look forward to next year's presentation.
Arco physio.
I'll go to the
Newest physio in the Northern Beaches.